Hi, good afternoon, and thank you so much for joining us today for the PSYCKES Primer for Emergency Department staff. My name is Krista McLaughlin, and I'm with some of my Office of Population Health and Evaluation colleagues, and shortly we'll be joined by some of our Office of Hospital Care and Community Transition folks, and we're really excited to provide this training for our ED frontline staff today. So before getting into the training itself, just a few housekeeping items. You might have already noticed that all phone lines have been muted to prevent background noise. But if you'd like to ask a question at any point during today's training webinar, please utilize the Q&A box, which is located to the right of your screen, or if you've expanded to the view, the full view of the webinar, you'll just need to hover your cursor at the top center of the screen and select from the menu the Q&A option. We won't be monitoring the chat feature, so we do request that people utilize the Q&A feature for their questions and make sure that you're submitting your questions to all panelists, which is the default. You don't want to submit to just the presenter because if I'm busy presenting the slides, I may not see your question come in, whereas we have some colleagues on the line who'd be able to assist. And then today's training, I mentioned a little bit earlier, but we will be recording today's training, and the recording from today's training, as well as the slides and additional training materials, will be available shortly after the presentation. All right, so let's take a look at the options that we have for the agenda. So one of the first things that we're going to be discussing is why now, why PSYCKES? So a little bit of background of why hospitals are going to be utilizing the PSYCKES application. Then we're going to do a overview of what PSYCKES is and giving you a little bit of background. I know that we have some folks on the call that already have PSYCKES access, but this will be one of the ways that you're going to be able to see a little bit more information about that background, as well as getting some tips and tricks. But we're going to spend the majority of the time for today's training learning how to log into the application, how to access patient level data in the application, and how to review a clinical summary. And then we will leave plenty of time for training and technical support, as well as having an appendix where if we're not able to get to certain pieces of information today, we'll make sure to include them in the appendix of these slides so folks have the opportunity to review. All right, so I don't believe I have any of my OCT colleagues on the phone quite yet, so I'm just going to go through this slide, and then if we have any of our OCT individuals join us, we can have them provide some additional data here. But the reason why individuals or hospitals are now using PSYCKES is that there's new regulations related to individuals presenting to EDs with behavioral health concerns. So all emergency departments are supposed to review records, including checking PSYCKES. Oh, I just think I paused my screen, so let me pull that up into view. Sorry about that. So why now? So that's what we're talking about. So for the emergency departments, it's going to be required to review records, including checking PSYCKES, and you want to use PSYCKES to help screen to determine if a patient is meeting these complex needs. But for EDs with a psychiatric inpatient unit, those are going to require a couple extra steps with these regulations, where they're going to help with coordination discharge planning with care managers. And so that's another way that PSYCKES can come into handy, because we'll be able to identify if an individual has a care management agency or a health home attached. Also needing to schedule and confirm an appointment for psychiatric aftercare within 7 days following a discharge. So you'll be able to use information in the clinical summary to help identify what are some other providers this individual is seeing, and then sending a discharge summary to the aftercare providers. We also have an option in the clinical summary to be able to upload documents in order for staff to access for that client. So if this patient is being seen in multiple different hospitals or in multiple different providers, if you upload a document to the clinical summary, it'll be available for all of those different providers with consent. All right, so here's a little bit of more information about how PSYCKES can help. So we mentioned that the PSYCKES clinical summary can help support that patient record review, integrating all of this different information that we have available across the state. Has a complex needs flag built in to allow providers to know who's hitting this complex needs, as well as providing the criteria for why they're hitting that flag. It identifies any existing care management program and contact information, so hospitals have that to use to make those care coordination calls, and then identifies previous providers and the level of engagement in care. So you can see some of these outpatient providers that the client or the patient is interacting with and how often that they're engaging with them. And then supports secure real-time sharing of discharge summary and other documents such as a psychiatric advance directive or suicide prevention plans. So currently we have close to 80% of the New York State hospitals already have access to PSYCKES. So the majority of hospitals are already far ahead of the game and ahead of these regulations. And we have over 2,700 ED or CPEP staff users self-identified, as well as over 4,000 psychiatric inpatient staff. All right, so let's do a little bit of an overview of what is PSYCKES. So the PSYCKES application is an online web-based application that is secure and HIPAA compliant. And the main purpose of PSYCKES is for sharing Medicaid claims and encounter data, as well as other state administrative data, and does this by putting this information into a user-friendly format. And the application is designed to support not only data-driven clinical decision making, but also quality improvement across population health. So what are some of the details that are going to be available via this data? So the data sources integrates over 10 different health related data sources. So one of our largest buckets is going to be the Medicaid claims information. So that's going to be including things related to medications, outpatient and inpatient services. We also have information related to um, the residential services. So that's all coming from Medicaid data, but the Medicaid data tells us what has been paid for and not the associated clinical documentation. So for example, for radiology, we'll be able to tell that this person had an X-ray, but we won't have the results of that X-ray, for example, because that's not included on the claim. But some of the other databases that we have, and unlike Medicaid claims where there is a bit of a lag from the time that the service occurred to the time that it'll be available in PSYCKES, these other databases are more of a quote unquote real-time data source because there we're getting that data anywhere between 0 and 7 days, and we refresh the clinical summary on a weekly basis. So some of that information includes the electronic medical record data from state psychiatric hospitals. So that's going to include diagnoses, admission and discharge dates, medications, and here we're actually able to get the lab value. So if there was a lab run at the state PC, we would be able to have the results because we have a direct connection to that data source. We also have information related to health home enrollment and care management provider information, and we're getting that directly from DOH's MAP service. So if a person is in outreach or enrollment, we have the name of the health home, we have the name of the downstream care management provider to help with those connections. We also have information from the state's incident management reporting system known as NIMERS. So information related to suicide attempts, for example, that will be available within the clinical summary. And unlike Medicaid data, which has a default look back period of 5 years, what you can get from some of these other databases is a farther look back. So if somebody indicated a suicide attempt in NIMERS for a patient 10 years ago, 12 years ago, that data will still be available in this person's clinical summary. We also have information related to court mandated outpatient treatment, including which is TACT, which is going to show AOT order dates and the treatment team contact information. We also have information for the Children and Adults Integrated Reporting System known as CARES. So that's going to include client level data on individuals receiving high intensity outpatient like ACT, as well as information for residential services, including admission, discharge, demographics, and certain risks or instruments. We also have information related to New York City specific areas. So some of the data sources that we have for New York City specific areas would be the DHS data, so the New York City Department of Homeless Services. So that would indicate somebody if they've had homeless shelter or outreach services, the shelter name, program type, placement date, exit reason, even the shelter director contact information if available. We also have information for correctional health services coming from Rikers, would include the name, jail admission date, and discharge date, release to, if they were placed in mental health residential treatment whilst they were at Rikers, and their behavioral health diagnoses and any scheduled follow-ups or referrals given during discharge. And then one of our last data sources that we have from New York City is the Department of Mental Health and Hygiene. So we have client level data for intensive mobile treatment, mobile crisis services, as well as those that have AOT referrals under investigations. And then one of the last things that we have would be data that's entered in by the provider or patient themselves. So I mentioned this a little bit earlier in the slides where we were talking about being able to upload plans and documents directly into the clinical summary. We also have the ability to conduct certain screenings within the application. So if there was a suicide screening or a depression screening that was conducted, whether it was in My Choice, and then that would be available, those results would be available in the clinical summary. So a lot of different data sources are available in PSYCKES. It's not merely just Medicaid data, and we're able to integrate that into that clinical summary view. So we have over 12 million patients available in PSYCKES with a clinical summary, and those individuals include those that have a Medicaid funded behavioral health diagnosis or treatment, have had a stay in the state psychiatric center inpatient, or had received outpatient services, or had been enrolled or outreached in health home. So here we're looking at what's known as the brief clinical summary. So as part of a high-risk quality collaborative from a few years ago, OMH conducted site visits with various hospitals and gathered information on how users were accessing the clinical summary, whether it was a printout, if it was something that was uploaded into their EMR, or if they were logging into the PSYCKES application. And then also ask those users, what were they finding the most useful or valuable pieces of information that they could find in the clinical summary? So from those visits, we found that users wanted the most critical information in an easily identifiable format. They wanted to be able to optimize time when reviewing clinical summary to get the full clinical picture, especially when you're in the emergency room, and have it fit on one or two pieces of paper that was printed out. So this is the brief overview, which acts as almost like a cover page to the rest of the full clinical summary. So on this brief overview, you're able to see some of the patient information, identifying information up at the top here. You're seeing the care coordination information, so that care management and residential contacts you can see here. You could see notifications like the complex needs, as well as why they're meeting that specific criteria. You can see if there's any alerts, so if this person had any suicidality, opioid overdose, or homelessness services, you'd be able to see that in the alert section. We also have any of their active quality flags, diagnoses broken up into the 5 most recent and the 5 most frequent in the past year. Outpatient providers, so these are a mix of medical or behavioral health providers that this person has seen in the past year. And then all hospital and crisis utilization, and this is going on for the past 5 years. So you can get a better sense of what their utilization is, especially at hospitals, for a longer period of time. And this all came from those user feedback sessions. So it was really, really helpful and made for a really great new feature that we were able to add to the application. I think about 5 years now. All right, so let's talk about hospital staff, how you get PSYCKES access. So hospitals are going to be obtaining PSYCKES access from security managers at your hospital. So as of December 2025, as I mentioned, over about 80% of hospitals already have PSYCKES access and registered security managers. So we are expecting all hospitals to have access by the end of the year. So You would either ask your supervisor or administrator who your hospital security manager is. You also have the option to email the Psyches help desk to find out your agency's security manager. I will also be providing a list of resources and materials for our hospital users, which will include a Psyches users table. So in that table, you'll be able to look up your individual hospital and see, does my hospital have Psyches access? Yes. Does my hospital have security managers? If yes, we'll have a second tab where you can look up your hospital's security manager. I will admit that because the Excel will be from December 2025. There could be updates since that time. So you always have the option of first, checking in with your direct supervisor or emailing Psyches Help for the most up-to-date information, but we will provide that resource to give people a head start in order to, identify if your hospital already has this access and who to contact to grant yourself and get yourself access. So once the security manager grants access, the staff will obtain and need to activate their token. And I've provided slides in the back of today's training, time dependent, but you will have those steps for how to obtain and activate your token. And then once you've had your token, you can activate and you're ready to log in. That'll be the first time you log into Psyches. All right, so let's talk about what logging in looks like. So you'll always want to go to our Psyches homepage. This is a great page for you to bookmark and save, so you don't have to, search for Psyches. I know there's a lot of different spelling of Psyches that can happen. So if you bookmark this page, this will be the page that you can always go to Psyches to log in, and then click log in to Psyches. You don't want to bookmark the login page because if that URL has to change for a reason later down the line, that'll be a broken link, but we'll never change our homepage, so you don't have to worry about that. All right, so once you've selected log into Psyches, you want to select the external local provider. So if you're not a state employee, this is the way that you would be logging into the Psyches application. So you would select log in. And then what you would do is from the token information and user ID information that you're going to get after your security manager grants your access, you would input your user ID in this first line. And then what we're seeing on the right-hand side of the screen is how you would log in using a mobile token. So what you would do is you would enter in your PIN, which is an 8-digit PIN that you create in order to log in to the RSA and get a passcode generated. So it's a two-factor authentication that happens that you as the user have to first create your PIN that you can use for all subsequent logins after. And then you would go ahead and copy and paste the passcode into the passcode field. So you're not inputting your PIN into the passcode for a mobile token, you're just inputting the passcode that generates every 60 seconds. All right, and then the next page would be you'd have to click to abide by the standards and HIPAA confidentiality standards that we have here in the application. So you hit agree. And then for the very first time when you log into Psyches, you're going to get prompted to take a brief survey that asks you 3 questions related to your role and where you work and what your primary work setting and program type is. So here's a screenshot of somebody identifying that I work in both the mobile crisis and the emergency department CPEP. So you can pick up to 2 in that setting or program type. And this will only pop up the first time you log in, and then on an annual basis, on your anniversary date, you'll get prompted to see like, hey, did anything change since the last time you were in here? And then you can say either, nope, continue, everything's the same, or you can make any of those updates as needed. All right, so let's talk about how, as a user, you're able to get access to patient level data. So patients can be linked to the hospital in one of 2 ways into your hospital view within Psyches. So automatically, if you have billed for a patient anywhere in your hospital within the past 9 months, that person is going to be linked to your view. So when you're running certain cohort searches in recipient search, like if I want to identify who has a diagnosis of diabetes or who has complex needs, if this is somebody that has been billed for in the past 9 months, they will be automatically included in those search results. However, if you want to be able to drill down to see the client level data, that's when you're going to have to do some of the manual attaching and the manual linkages. So there's a few different ways that you can manually link a patient to your view. So if the patient has signed one of the consents, which is either the PSYCKES consent form, the health home patient information sharing consent form, or a BHCC consent form. We also have the option for verbal consent, but that's going to have a different level of access to client level data, which will be discussed on the next slide. There's also the break the glass scenario. So if there's a clinical emergency, you have the opportunity. So I didn't have a time to get a consent, or the patient was in no mind space to give me a consent, but this was a clinical emergency, you have the opportunity to break that glass. And then lastly, I don't have a consent, it's not an emergency, and it was the first time I'm seeing this patient, but they're being served by us or being about to be transferred to my hospital. I have the opportunity to maybe link them manually so I don't have to wait for a couple months for the bill to come through and make that automatic link. However, that option won't allow you client level data. So here's the breakouts of all of the different levels of access. So the signed consent is definitely the gold standard. That's going to allow access to all available data at that client level, including data with that's specially protected, such as substance use, HIV, family planning, genetic testing. And not only it will give you that data for all data with special protections, if available, but also will allow that for 3 years after the last billed service. So if you're somebody in the emergency room, maybe you're more likely to have clinical emergency access, but if this is somebody who might end up going into the inpatient, if you're able to get a consent, that means that that consent covers the entire hospital. So that means that it's one less step for your inpatient colleagues to have to do. So if you're able to get the signed consent, that's allowing for the most amount of data to be released and for the longest period of time for you to be able to access that data. Because as I mentioned, the clinical summary gets updated on a weekly basis. So if you get the signed consent and you look up the client a few months after, if they come again to your hospital, you don't have to go through the process of enabling again, and you could see updated information that's now available. There's also the verbal consent that came about during the COVID-19 crisis. So during that time, we allowed the verbal consent, which allows access to limited data, which excludes data with special protections, and it's only available for 9 months after you enable that access. So verbal consent is, there's sometimes where you don't have the opportunity to get a signed consent, but that you are able to talk through the consent with the patient themselves, and they might verbally consent to their data, but it would only allow access to data that does not include specially protected data, and only for 9 months. The clinical emergency allows access to all available data, including that data with special protections, but for a limited duration of 72 hours. So as I mentioned, vast majority of emergency department presentations are those clinical emergencies, but getting those signed consents could be a good practice and help those other colleagues in your hospital. And then I've already mentioned for the attestation of service that this will link the client or the patient to your recipient search reports, but won't provide you access to drill into their clinical summary. So the PSYCKES consent details, you can see an example of what the PSYCKES consent looks like on the far right here. So it's going to include a brief overview of what PSYCKES is. It's going to share what types of information providers can see if the patient grants consent. It also provides a place to indicate if consent is given or denied. So if you're trying to track, like the last time I asked this person, they denied consent, but I'm going to ask them again during this next visit if they are willing to sign consent this time. And in the spaces that you see highlighted in blue here, there's a space for the patient's name, date of birth, Medicaid ID if available, and their signature to confirm their choice. So in order to access the pre-populated PSYCKES consent form, which will include information related to, like that'll list your hospital specifically, as well as who are the contacts the patient should turn to if they have questions or if they want to withdraw their consent, you want to access that within the application itself. So after you log into PSYCKES, you can navigate to the registrar tab and to manage PHI access. And what you see in this blue box over here, this is the ability to get that consent that's filled out with your hospital's information pre-populated in English or in Spanish, but we also have other languages. So we have the 10 most spoken languages available on our website, and that'll take you to a new window that will include that access. But that would not be pre-filled. So as always, staff should follow their hospital's protocols on how to access consent forms. So including PSYCKES consents alongside other registration intake forms, having a paper or an electronic format, whatever your hospital protocols have established, that's the protocol that you'll want to follow. All right, so step one, how do I go about searching for the patient that I'm trying to enable access for? So you'll see here in the recipient search section that you have an individual search tab versus a cohort search tab. So if I'm trying to identify a single person, I want to use this individual search. And starting with one of the unique identifiers is one of the best ways to be able to, pull just a single client. So if you have a Medicaid ID or social security number, you can indicate that here. If you don't happen to have that information, there are other options. So you can do a combination of name and date of birth. You also have the option to add known client characteristics to help narrow down results. So I know that this is a John Smith born on this day, but there could be, hundreds of John Smiths. So I know that he is identified as this race or this ethnicity or lives in this county. You have a couple options below if you need, if you don't have opportunity to get a unique identifier. So let's say, for example, for this, we have a unique identifier. We have this person's Medicaid ID. We would input that in here and then select individual search. So from there, I need to confirm that this person is the correct person. And another thing that you're able to do, and this is one of the brand new features that we recently released earlier this month, is this planning considerations column. So even without enabling access, you have the opportunity to identify that Jane hits complex needs. So Jane is meeting the complex needs flag. Now, if I want to know what specific criteria that Jane is hitting to get that flag, I would have to enable access to see that information. However, in this planning considerations column, you are able to identify any of those individuals who are meeting either a certain planning consideration notification or has certain documents uploaded into their clinical summary. So again, I'm going to confirm that this is Jane Doe. This matches her date of birth. That's her Medicaid ID. All of this information here is to help me identify that this is the person who's maybe sitting right in front of me, because it doesn't help to access data of another patient who's not the patient that's sitting in front of me. So I want to go through this process, and if it's not the correct person, you just would go back and modify the search as needed. But for this example, we're going to say, yep, this is the Jane Doe that I'm seeing. I'm going to go ahead and enable access. All right, so now I have to decide what's the appropriate level of access that has been granted to my hospital. So did the client sign a consent? And if so, what type of consent did they sign? If they didn't sign a consent, did they give me verbal consent to view their information, or is this determined to be a clinical emergency? I need to break the glass in order to see this information because this client is in imminent risk of harming themselves or someone else. Or is it that I'm served this person, they just showed up today, but I don't have a consent. It's not an emergency, but I want to be able to link them for recipient search results. So let's say for this example, I'm going to say that the client or the patient signed the PSYCKES consent form. I'm going to go ahead and check that off and then hit next. So one last time, I'm going to be asked to confirm that this is the correct individual before enabling access. So I have an opportunity to, again, check the name, date of birth, Medicaid ID, and address to confirm. And then how do I know this is the correct person? So I can either attest to the client's identity, or I can indicate that this person showed me one photo ID or two forms of non-photo ID. And then at the bottom here, it's going to summarize the level of access that the hospital as a whole has. So Main Street Hospital. So it's not granting access to a specific user. It's granting access at the hospital level, including emergency department, inpatient, clinic, etc. So this is going to give access to the Main Street Hospital for all available data for 3 years. And again, that renews automatically with build service. So I have the opportunity to enable, and maybe I'm going in to, do multiple enabling of consents. Maybe that's my role at the hospital, or maybe I'm just going to enable and drill right into this person's clinical summary. So here's an example of when I enabled that access, and now I can see, unlike before when I looked at this, I had no access. Now I see that I have the PSYCKES consent and now can drill into this person's clinical summary. So let's talk about breaking the glass in clinical emergencies. So if a patient refuses or is unable to consent because of a clinical emergency, the provider is permitted to obtain PSYCKES clinical summary without consent. So a clinical emergency is defined as a medical or behavioral condition for which there is an immediate need for treatments, and symptoms are sufficient in severity that the absence of immediate treatment would likely result in serious harm to self or others. So below here is a criteria for breaking the glass that may include but isn't limited to. So threats or attempts of suicide or serious bodily harm, homicidal or other violent behavior by which others are placed in reasonable fear of serious physical harm, inability or refusal due to mental illness to provide for their own essential needs, and overdose, sedation, altered mental state, catatonia, and otherwise non-responsive. So those are some examples. And providers are responsible for ensuring that the medical record supports emergency access by documenting why and how the client meets the criteria for a clinical emergency and attesting with their signature date and timestamp. So if there's a need to enter in or break the glass, you just want to make sure that you're documenting that information and have that available in case later on there's an audit, or if a client has a question as why their data was looked at, you have the information that you need to be able to respond. All right, so let's talk about the clinical summary. So the clinical summary summarizes up to 5 years worth of treatment history for a single client and integrates that information from all of the different databases that I shared earlier, and puts it in almost an EMR style of being able to view this information section by section. It also summarizes the episode to help support rapid review and links episodes of care to detailed dates of service, including diagnosis and procedures. So the way the clinical summary can help hospital-specific users would be able to identify patients with complex needs, identify patients who have a pattern of ER visits but not otherwise engaged in maybe outpatient or community care, help form a differential diagnosis by clarifying a history of patient care and services, and then also being able to obtain contact information to help coordinate care or provide referrals. On this slide, what you're going to see is what makes up the complex needs criteria. So if your patient is matching or hitting one or more of these criterias, they're going to be identified as complex needs. So on the far left, you're going to see what is the general criteria, which would be for any age. So if any patient of any age hits any of these below criteria, they're in that bucket. Whereas the additional eligibility criteria is for children and adolescents from 0 to 20. So in this group, only people who are within this age range and hit one of these criteria would be considered complex needs. So here's another look at the brief once again. So here we can see highlighted in this blue color up at the top here this is an example of somebody being enrolled in a health home program. So I can see when they were enrolled in health home, what their status is, and also some main contact information. So a main contact referral information as well as the member referral number. And we also can identify who's the care management agency attached to this client. And then in the notifications, again, you can see specifically what is making this patient complex needs. So they're complex needs due to a few different reasons here. So one of the last reasons I can see is that they've had 4 more ER visits for mental health purposes in the past 13 months. I can keep scrolling down on the brief overview to get more details. So here's an example of some of the outpatient providers information that we can look at. But you can always get more information, like as I mentioned before, the brief overview can act as almost like a cover page. But if you're looking to, get more information or drill down deeper, you can go to the full clinical summary. And in the full clinical summary, you have the opportunity to export to a PDF or Excel. So you have that option there, and then you can see all of the different sections below. So we have a general section, we have the current care coordination, and then we have the notifications. Below that, you're going to see some of the alerts as well as social determinants of health. So as I mentioned before, alerts would include information related to suicidality, opioid overdose, as well as homeless criteria. And then we also have information related to social determinants of health that we're getting from Z codes and billing. So that's our data source right now. So it's an underreported data source that we have, but we know that hospitals are actually doing a great job of indicating SDOHs using those Z codes. So you have the ability here to see if the different SDOH conditions and then what those domains are. So for example, we can see that this person has been identified as having issues with homelessness via the Z code. So you have the ability to actually click on any of these SDOHs and see more details related to what provider gave them that Z code, on what date, what service setting, and any other diagnoses that were given during that time. In the quality flag section, so PSYCKES identifies clients flagged for quality concerns in order to alert clinicians of possible unmet clinical needs. So here's an example of somebody who has a variety of quality flags or quality concerns. And a lot of them have to do with hospitalization. So you can see that this person is frequently being hospitalized multiple times in over a year. And we can also see different hospital outcome measure sets and other things like related to health home and mental health placement. So this is some of the information that you can see in the quality flags, and you have the ability to look at the definitions if you want to know what does it mean for somebody to have 2 or more ER behavioral health flags. And so you can have the ability to look into the definitions. So the plans and documents, so users can either select a document to view if one already exists. They can add documents by uploading, or they can use create new by using one of our standard templates, which we have the Stanley Brown template for safety plans, as well as the NIAPR Psychiatric Advanced Directive. So you can use those templates and then upload those documents to the clinical summary. So here's an example. If I already had a discharge summary or a discharge plan, I can upload the discharge plan directly into the clinical summary. And that way, any other providers who are working with this client and they're enabling access to them in PSYCKES, they can see that information. So it's a way to share that. All right, so diagnoses. So we separate these between behavioral health and medical diagnoses. And the way that these are listed out here is that we're going to show you the most frequent first. So in this example, this is schizoaffective disorder is the first diagnosis listed here. So it's the most frequently diagnosed diagnosis this person has, diagnosis. So you can see the date of service, the service type, the provider name, as well as any other primary, secondary, and quality flag related diagnoses for this individual. So you would see that for every single date of service that use that diagnosis as part of it. The integrated view of services over time, this is a great way to be able to take all of this information and have a visual way of understanding either gaps in care, medication adherence issues, lots of different things. So when you're seeing something that's a straight line like we're seeing for Medicaid enrolled, this is basically telling me that this person has had Medicaid coverage since July 2021 up until now. So I see that there's been no break in Medicaid, so I can see that using this straight line. Whereas when you see singular dots, it's like a singular visit or a singular hospitalization stay, for example. So here's an example where if I'm hovering over this dot, and this is for an emergency room for medical purposes, I can not only see when that service specifically occurred, but where. So that's one of the interesting things that you're able to use the IVOS for, is picking up certain patterns. So for example, we can see for this individual that they have quite a number of emergency room visits and inpatients, but not that much outpatient providers. So maybe that's something that this client would likely maybe not come so often to the emergency room if they had some outpatient support in the community. All right, so then we have medications, which are broken up between controlled substances and then behavioral health and medical. So you have the option here to either toggle, and each of the sections you have the ability to change into a graph, kind of like what we were seeing with the IVOS, or the standard view is the table. But you also have the ability for medications to select the see details icons. And there you can see the individual pickup. So for example, this medication this person has been on for over 4 years. So you have the ability to drill down to see each individual pickup for that specific medication, as well as the brand and generic name, drug class, strength, quantity dispensed during that specific order, days supply, even the pharmacy in which they picked up that medication. And then we have outpatient services. So these are broken up between behavioral health and medical outpatient services. So some of the information that you're going to be able to see there is the service type, the name of the provider, first and last date billed, how many visits they've had with this specific provider, and then what was their most recent primary diagnosis and what were some of their more recent procedures. And so you have the ability to look at that information. Again, you can change this into a graph, and then you have the ability to drill down to see the individual visits. And then crisis services, this is combining certain crisis services like mobile crisis as well as residential crisis services and putting them in a specific crisis services box here. So we can see, for example, that this person's had some mobile crisis follow-ups as well as responses. And we've also seen that they had a crisis stabilization intensive stay during some of their time. So again, you have the ability to see the service type, the name of the provider, date of service or admission if it's a residential, and then visit or length of stay, primary diagnosis, as well as those most recent procedures. And then over here, we have the hospital and ER services. So unlike some of those other sections where you saw that we were breaking, medical from behavioral health, those were separate, we're combining them in this view. So in this view, you're going to be able to see both inpatient and ER services, as well as if it was for a mental health, substance use, or medical cause. So up at the top, you can see it will identify the service type, the name of the provider, admission and discharge date, length of stay, most recent primary diagnosis, and then the procedures per visit. So you're able to see that this person had a medical inpatient stay recently here. They stayed for about 14 days due to an injury on their spinal cord. And then before that, they were actually getting some CPAP services. And this is going to show some of the diagnoses. So for example, you might not have known that this person had unspecified intellectual disabilities, but this is a way for you to see that not only in the diagnosis section, but also what service actually gave that diagnosis. So you'd be able to see that in this section here. All right, so we have some training and technical support I want to make sure that we discuss, and then I want to make sure that we're leaving time to help answer any questions that might come in. So the hospital resource packet is going to be sent to all of the attendees from both today's training as well as the previous training, and that will include the PSYCKES hospital access user table. So that was the table I was talking about a little bit earlier. So if you're trying to identify if your hospital already has PSYCKES access, if so, who the security manager is, and if you have active security managers. We also have an action planning form and other resources used in prior ED PSYCKES implementation. So this is really for the leadership folks, but we're going to have this as part of the packet in general. So that's going to help with the planning to make sure that people have everything they need prior to implementing PSYCKES in their EDs. And then some of the resources that we are going to have for security managers is how they can go about granting PSYCKES access as well as revoking PSYCKES access, because it's just as important to be able to revoke access as it is to grant. Then for the PSYCKES consent script, we're going to have a consent script that can help users if they're trying to discuss what the PSYCKES consent is. It's a little paragraph to help explain that to the patients, as well as answers to frequently asked questions. So having that handy. And then also a PSYCKES summary checklist workflow, so making sure that you have some core competencies that that you and your hospital staff feel comfortable and know how to go through the PSYCKES summary checklist and making sure that you're, documenting and doing everything that you need to. And then activating token and logging into PSYCKES. So especially for brand new users who don't have access quite yet, this is going to be really helpful to, make sure that you're guided along the way of how to activate and then begin logging in. And then the last training resource is going to be how to upload a psychiatric advance directive into PSYCKES. So if you want to be able to upload that, these will be steps to show you how. So that's going to be part of the packet that you're going to be emailed along with the recording and today's slides. But we also have training resources that are available for all PSYCKES users. So this is the ones that I'm talking about previously. Those are for our hospital users. But if you're interested to see some other resources that can be utilized by any of our users, we have short how-to videos. So if you're more of a visual learner, this is a great resource. So this is like a 5-minute video a piece. So how to log into PSYCKES, how to look up a client and enter consent, how to review a client's clinical summary. These are videos that you can access using the link from this slide here, but it's also available if you just go to our PSYCKES homepage. We have user guides. So for each of the different modules within the PSYCKES application, we have a user guide written out to help give you more specific details about each of those modules and what those functionalities are. And we also have PSYCKES training slides and recordings. So we often on a quarterly basis post brand new trainings for people to register for if they would like to attend live like you folks are doing today. Or if you're not able to attend in person, not in person, but over WebEx, if you don't have the opportunity to join that meeting during that time, we record those trainings and then post them to our website. So you'll have the opportunity to visit or access that information later. And we do trainings based on user type as well as on specific modules. So if I want to do the training related to hospitals, you guys are in a great place today because that's the training that we're focused on today. But if you wanted to learn more about the recipient search capabilities, you also have the opportunity to join a training webinar that focuses just on that. And then lastly, we have a what's new section. So we just updated this a few weeks ago because we have quarterly releases that come out as you expect every quarter. So we just had our most recent one in early April where we add brand new features to the application, as well as have a training webinar that goes over some of those new features. So when you land on the home page, you'll see the what's new section updated each quarter. So in case if you hadn't logged in in maybe a month and then you go to log in again, it gives you some tips on what's going to be new when you log in. These new feature training webinars are also an excellent opportunity to share what, after you've had an opportunity to use PSYCKES, like what would you love to have in the application, or what do you wish that the application can do based on the work that you're responsible for? So that's another option to use for those training webinars, either attending those and sharing some of your thoughts, or even reaching out to the PSYCKES help desk to share. And that brings me to my next slide. So talking about what are some of the technical supports that you have available. So if you have any questions related to data and functionality of the PSYCKES application, you can contact our PSYCKES help desk that's available 9 to 5 Monday through Fridays at the psyches-help@omh.ny.gov. We strive to give responses within one business day. Sometimes there could be a little bit more of a complicated question, so we'll at least give you a response letting you know that we're looking into it and then getting the appropriate people who can help answer some of those questions. However, if you're having an issue with your token or logging in, that's going to have to go to our OMH help desk, which is the health help at its.ny.gov. Those are the folks, because tokens and login is something that's used for all OMH applications, not specifically PSYCKES. So they're the ones that are usually able to help with those concerns, but you can always reach out to our PSYCKES help desk and we are be more than happy to play the middleman to help get you to a solution that's satisfactory and you're able to log in, because we don't want people to have the barrier of logging in be the reason that they're not utilizing this really helpful tool. And then lastly, you can contact your OCT hospital program specialist or email the hospital care at omh.ny.gov. And those folks may be able to even do an on-site demo of the PSYCKES capabilities for your hospital if you need. So with that, I know that we had Flavio join. I didn't know, Flavio, if there was anything that you wanted to specifically share, or if we can just go right into the questions.
Yeah, thank you, Kristen. I just want to say, sorry I'm late. I had some IT issues, but I really want to thank everyone for coming and for being here. I know that you're the front line of the emergency department, and it's not an easy place to work, not easy work to do. And we hope that sort of these tools that are built into PSYCKES will make it easier to implement into your workflow the new regulatory requirements and so forth. So I just want to say thank you um, and happy to address any questions that you may have.
Thank you, Flavio. So I'm going to turn it over to Michelle. Michelle, can you let us know if we got any questions in the Q&A?
Kristen. One just came in, and this is the only question we have so far. So this person asked, with the new New York public health law, when are ER doctors required to log into PSYCKES? So for example, if a Medicaid patient with a history of a mental health diagnosis is in the ER for ankle pain, but not for a mental health condition, is the ER doctor required to log into PSYCKES?
Yeah, that's a great question. Do you mind if I take this one, Kristen?
Please.
That's a good question. So it's not in the public health law. It's in the Department of Health regulations. So if you're a wonk, if you like to look at regulations, it's in part 405.19 in the Department of Health regulations. And if you contact us at Hospital Care, we can give you the citation. So what it says is that every emergency department, when taking care of someone with a behavioral health presentation, has to sort of get a suicide screen, a violence screen, a substance use screen, and also sort of to have them sort of be looked up in PSYCKES and to see if they meet the complex needs definition. And it doesn't necessarily have to be the ER doctor. It can all depend on how the workflow works for each individual emergency department. Every ER is different, so it's going to depend on how it gets implemented. And there's lots of ways to do this. And we can work with the leadership of the ER to sort of figure out like what makes most sense for any particular setting. If the individual has complex needs, if the emergency department is in a hospital that has an inpatient psychiatric unit, and if the individual is being discharged, there's a few more requirements. So discharging individuals who meets that complex needs definitions from emergency departments in hospitals with inpatient psych units, which we call the 939 hospitals. For that much smaller subsection of individuals, you need a scheduled appointment within 7 days, for follow-up. You need to share sort of discharge note, discharge summary with the receiving outpatient providers. You need to engage care management if the person is open in care management in the discharge planning. PSYCKES can help with all those things also. You can see if the person's receiving services already somewhere, if they are open to care management. So that can really cut down on the amount of sort of work it will take to find that out. So that's a neat tool. So all emergency departments have to use PSYCKES to see if someone meets that complex needs definitions, for individuals who come with a behavioral health presentation. But then the extra discharge planning requirements are only from the 939 emergency departments discharging individuals who have complex needs. So it's like two different parts of that regulation. I hope that answers the question.
Thank
Thank
you,
you,
Flavio.
Flavia.
It looks like, oh, we got a couple of other questions in. And just a quick follow-up on that initial question that I just asked. If the patient does not have a behavioral health presentation, then we don't have to check psyches?
If so, the way the regulation is written is it's for individuals who come with a behavioral health presentation. Now, specific hospitals, right, might want to write internal policies that are broader, right? So I don't want to, so I'm speaking to what the regulation is, but if the director of your emergency department or if your hospital chief medical officer decides, you know what, I want to make this broader, then hospitals are free to develop policies that are broader than the minimum requirement of the regulation.
Thank you, Flavia. I appreciate it. We did have one other question come in about breaking the glass as it relates to mobile crisis visits. So this person provided an example that we may receive a referral from a family member from out of state who reports behaviors of concern, getting reports from neighbors, etc. So we search our EMR and no record without hospital. In these instances, psyches can inform presence of risk factors, if any, to the team and more generally before going to the patient apartment or their door. Um, so I'm not sure if that's more of a question we would follow up on, or if we wanted to just describe maybe the breaking the glass criteria here.
Yeah, so I think like we can always follow up with this person individually if they have like a specific use case, but oftentimes if someone's calling 988 or calling for mobile crisis, that means that this person is probably in imminent risk of harm to themselves or others. It's a crisis. So that is the intention for the Break the Glass. I will also add that for mobile crisis teams, we did create a PSYCKES mobile app for both iOS and Android. So you have the ability to bring, let's say, an iPad or a tablet with you in the mobile crisis van or car. And if you get the call saying, hey, I'm getting a 988 referral for a crisis, or getting a contact from your mobile crisis dispatcher saying like, hey, there's a crisis going on here, there is that opportunity using the mobile app, not just the web, to enable that access using that mobile app for PSYCKES to enable that access and view that information prior to going to see that person. So you can get the risk and all of those other details that you discussed.
Thank you, Kristen. It looks like those are all of our questions that have come in.
Okay, so let me just bring us back to the page that we were just on with some of the training and technical assistance. So I will share that the appendix with this slide deck is going to include things like how to obtain a token. It's also going to showcase the mobile app. So you have the ability to see a little bit more of that, as well as how to withdraw a consent. But with that, what I can do is I can give some folks some time back in their day. And as I shared earlier, that we are going to share the recording, the slides, as well as the training materials that I discussed in that previous slide to all of the attendees from today's training, as well as those who were part of last week's training. And we will eventually also post these recordings onto our public website, but we want to make sure to get into the hands of the people that were in attendance today. I also had some folks reach out to me saying that they sadly couldn't attend today's training, so they asked me to add them to the listserv, which I most certainly will do. And again, I just want to thank everybody for taking time out of their busy day to learn a little bit more about the PSYCKES application, and encourage folks to reach out to our PSYCKES help desk if you have any questions in the meantime. But until then, I hope everybody has a great rest of their day, and thanks so much.
Thank you, everyone.